Hi, my name is Saba Shaikh. I'm a breast medical oncologist at UT San Antonio, and I'm so excited to be joined today by Dr. Shanu Modi from Memorial Sloan Kettering to discuss the Destiny Breast 11 press release on San Antonio Breast Cancer Symposium Snippets. Thank
Hi,
you, Dr.
nice to be
Modi.
here. Yes, hi, thank you. Nice to be here.
Can you tell us a little bit about the design of the study and what we know so far from the press release?
Yeah, very exciting press release yesterday. The Destiny Breast 11 is a multi-center global randomized phase 3 neoadjuvant trial for patients with early stage HER2 positive high risk breast cancer. And so, high risk for the trial was really defined as patients who had tumors that were larger than 5 centimeters, or patients who had positive lymph nodes, or patients who had an inflammatory presentation of their breast cancer. So these were the high risk patients. Everybody had centrally tested HER2 positive breast cancer to participate, and they stratified based on the hormone receptor status. And so these patients were randomized 1 to 1 to 1. It was a 3-arm trial. So arm A of the study was the monotherapy trastuzumab deruxtecan or TDXD arm of the study, and they got 8 cycles of conventional TDXD for breast cancer, which, as you know, it's the 5.4 milligrams per kilogram every 3 weeks. Arm B was the other experimental arm. And that in that arm, it was a great compromise. It was a sequence arm, so patients got 4 cycles of TDXD, and then they got the THP, our standard stalwart regimen of weekly paclitaxel and HP. And then the third regimen, or the third arm, sorry, was the standard of care arm. And in this case, the standard of care that was used was dose dense AC followed by THP. Patients were randomized. I think over 900 patients ended up being randomized to this trial. And the primary endpoint was to look at PAT-CR. So the trial was designed a few years ago, of course, and the primary endpoint was PAT-CR in the breast and lymph nodes, invasive PAT-CR, and the secondary endpoints were event-free survival, overall survival, invasive disease-free survival, safety, things like that. So yeah, a very exciting neoadjuvant trial. The first time we brought TDXD into the early stage setting in HER2 positive breast cancer.
Very exciting. And can you tell us a little bit about your thoughts about having the anthracycline-based chemotherapy in the control arm?
Yeah, I mean, so this was a global study, and I have to say the ACTHP arm was really is probably the most standard, conventional, traditional, time-honored treatment for high-risk HER2 positive breast cancer. It was an effort to remove the anthracycline that we saw the introduction of the TCHP arm, and although there's no direct head-to-head, we have seen that it produces similar outcomes. And so it's kind of become a preferred therapy, maybe fair to say that around the world. But I do think ACTHP is still a standard of care, and this was a global study. And so in some ways, I think the results, as we've heard, are positive for the sequence arm, really showed just the strength of the data, if nothing else, given that the standard of care arm was ACTHP.
Absolutely. And so the study, interestingly, in the press release, they mentioned that there was a similar rate of ILD in both arms.
Yes.
Do you think that's related to just the 4 doses? And should we be screening for ILD when using TDXD in a neoadjuvant setting? What are your thoughts about that?
Yeah, so I mean, I think just to rewind a tiny bit, I mean, one first thing we heard was, and this was I think last year, we heard that the TDXD arm A of the trial was terminated early, so they stopped enrollment. And this was based on Data Safety Monitoring Committee's recommendation, obviously weighing risks and benefits. We don't know all the details, but it was a range of things that made them decide to stop that arm early. So that's, I think, the first interesting thing. And obviously, we want to understand why that was the case. Um, and then, of course, the press release tells us that the primary endpoint was met. We seek statistical and clinically meaningful improvement in PAT-CR with the sequence arm, which is exciting. And then they followed it up by saying the safety data was also actually in favor overall of the sequence arm. I mean, less overall toxicity in the sequence arm B, and they saw similar ILD rates. So that's really important. That's just a little tidbit of information. We obviously want to know details. What were the grades of the ILD? How many events? Were there any grade 5 events, obviously? So it's nice to hear that there was similar, that there was no big excess amount of ILD toxicity related to TDXD. In this trial, of course, there was intense monitoring. I mean, these are early stage patients. They got high-res CT scanned every 2 doses at baseline as well. So, I mean, obviously they were being watched very closely, and it's 4 doses, as you said. In most of the studies of TDXD, we see the ILD typically starts around between 4 to 6 months range. So they they perhaps were able to avoid a lot of ILD that way just by giving a shorter course of TDXD.
Yeah, very interesting because I know that's a very important toxicity for us to think about, especially in the early stage curative setting. So that was
Absolutely.
very interesting to see.
Yes. Yeah.
Um, So there's a lot happening in the early HER2 breast cancer space. Standardly right now, our patients with stage 2 and 3 disease will typically get some form of chemotherapy and anti-HER2 therapy. But there's some de-escalation approaches looking at less amount of chemotherapy, like Encompass HER2. There's also some studies that have looked at even starting with just the anti-HER2 backbone and then using a PET adapted strategy like Infergain. And of course, with the goal of not over-treating our patients, but we also don't want to under-treat the patients who may need, additional therapy to get to a pathologic complete response and hopefully a better long-term outcome. So, who in your mind would be an ideal patient for a regimen that was studied in Destiny Breast 11?
Yeah, great question. And I think this is what we're going to all debate and struggle with as we see the details from Destiny 11. And honestly, as we see results from Destiny 5 presented, right? The adjuvant, the Catherine type trial. Um, I mean, I guess I'll start by saying I do think TDXD is going to be a very important drug for early stage breast cancer. How we're going to use it is I'm going to be honest, I'm not 100% sure. What we really need details, I think, to figure that out. But I'm excited by the potential of this higher PAT-CR rate. I think some of the questions I have are what is the magnitude, or what's that delta? What is it? What is that actual number? I mean, I think that's going to be important. Um, how were the subgroups? Did what happens with ER negative breast cancer? What happens with ER positive breast cancer? Is there a group of patients that does really, really well? And of course, the last thing is the safety, and we talked about that earlier. I think that's the real balance here. So there's just a lot of information, and perhaps what I really should say, the most critical thing is, how does the PAT-CR translate to survival, right? At the end of the day, for early stage patients, our goal is to cure these patients. And while PAT-CR is an important endpoint, the question is, will that PAT-CR really translate to improve long-term survival for these patients? And I think without that information, it's sort of hard to know, I think right now, who I would use TDXC up front, who I would use it maybe on the back end in a Catherine type style. So a lot of details I think that we still need to know. If I had to just to make a general statement, I would say a higher PAT-CR rate would be really important in patients potentially who have high burden of disease. They start off with big, bulky lymph nodes, big masses. So that would easily be a patient I might think about a regimen where the PAT-CR rate was higher, and that might be an advantage to using it earlier rather than in the adjuvant setting. One of the other things we're going to have to weigh is we're going to use 4 cycles in the neoadjuvant setting versus 14 cycles in the adjuvant setting, and how that plays into toxicity and ILD risk again. It's going to be these are all going to be variables we'll have to explore as we figure out how to move forward with this drug. But I'm very confident it's going to be a new option for early stage breast cancer.
Yeah, that's a very good point that you brought up with the difference in the number of cycles in the neoadjuvant versus the adjuvant setting with Destiny Breast 05. So those data, I mean, we're waiting for those. We don't quite know what it'll show, but if I had to speculate, I would anticipate that it's going to be positive just based on how TDXD is compared to TDM1 in the metastatic setting. So, like you said, that's going to bring a whole host of additional questions of how do we sequence ADCs and when is the optimal time to really deliver the TDXD?
Right.
Um, what are your thoughts about using a predictive genomic assay like HER2-DX? Will you all be looking at something like that in the study?
Um, I mean, in general, I think the HER2-DX is a really exciting kind of emerging tool. It's not yet available here in the United States, but it's an exciting tool. I think what it fundamentally tells us is how intrinsically sensitive the cancer is to our therapies. What it doesn't tell us today is, what regimens to use, what drugs to use. And I think we probably do need to incorporate it prospectively in future trials in order to really, I think, understand how to use it for therapeutic decisions, for de-escalation, for escalation. So I think it has a lot of potential, but I think we still need more information from trials. Do I know if it was, I don't know if it was part of the correlative study plan with DB11. I think that's something we will find out.
Well, lots of interesting, developments happening for our patients, which makes us all excited. And we really look forward to seeing the data being presented later this year. And thank you so much, Dr. Modi, for joining us today to talk about this exciting new press release.
My pleasure. Yes, it's going to be another great year in HER2 positive breast cancer, I think.
Absolutely.